Good afternoon, everyone. So at the outset, I would like to thank ORDI for inviting me today. So in this Rare Info Series, we'll discuss today about hemophilias. So from genetics to therapy. So I'm Dr. Roopa from Medical Genetics Department. So people with hemophilia have low levels of factor 8. Either it's a classical hemophilia, factor 8 is deficient. In factor 9, Christmas disease, factor 9 is deficient, or in factor 11 is deficient in hemophilia type C. So the severity of hemophilia depends upon the amount of factor in the blood. The lower the amount, the severe is the disease. So prevalence, if we see worldwide, 1 in 10,000 males are born with hemophilia A and B. And in India, we don't have proper figures, but around it is 4 per 1 lakh population. And little bit of basic physiology before we go into the genetics proper. So we all know hemostasis takes place in 2 phases. So the first phase is primary hemostasis, which leads to the formation of platelet plug. Secondary hemostasis involves different coagulation factors leading to a stable fibrin clot. So we have 2 pathways, extrinsic pathway, intrinsic pathway, and these 2 pathways lead to a common pathway. So in the extrinsic pathway, damage to endothelial cells, endothelial tissue leads to activation of factor 3 and factor 7. And in turn, it goes into the common pathway. Whereas in intrinsic pathway, factor 12, 11, 9, 8 comes into play. And these are getting activated and goes into the common pathway, where factor in the common pathway, factor 10, factor 2, and factor 1 are the major contributors. So, whenever there is deficiency of factor 9 and factor 8 here, it leads to hemophilia. Whenever there is von Willebrand disease also, it leads to deficiency of factor 8, leading to bleeding disorder. So normally, this factor 8 is produced from the hepatocyte, and von Willebrand factor is produced from the endothelial cell. Just a minute. So this von Willebrand factor holds the factor 8 in a complex. So the gene for factor 8 is present in the X chromosome, and for the von Willebrand factor, it is present on the chromosome 12. So whenever there is deficiency in synthesis of factor 8 from the hepatocytes, this von Willebrand factor is lying alone, and it leads to hemophilia. And whenever there is deficient von Willebrand factor also, when the endothelial cells are not producing von Willebrand factor in correct amounts, it leads to factor 8 leads to degradation, and it also leads to bleeding disorder. So clinically, how does it present? In untreated individual, it presents with immediate or prolonged bleeding or oozing after injuries or tooth extraction or surgery. And it can also lead to renewed bleeding after the bleeding has stopped. It can lead to muscle hematoma, intracranial bleeds, GI bleed, and bleeding after circumcision, or delayed wound healing after circumcision. Or in severe hemophilias, it can present with spontaneous bleeding into joint, which is called hemarthrosis. So these are pictorial representation of severe bleeding after tooth extraction, hemarthrosis, muscle hematomas. And these children have hematomas on their forehead because of banging their head somewhere. And this is all called the goose egg appearance. So severity and symptoms depends upon the clotting factor in the blood, clotting factor activity in the blood. So in severe hemophilia, the clotting factor activity is less than 1%. So presentation is before 2 years, and it can present in the neonatal period itself, which causes large cephalhematomas after instrumental delivery. And in untreated toddlers, it can result in bleeding from minor injuries, or it can lead to goose egg appearance on the head, or it can lead to spontaneous intracranial bleeding, or after a trivial injury, it can lead to intracranial bleeding. So the most common differential diagnosis we consider is battered baby syndrome. And as a child grows, the frequency of bleeding increases, and it can lead to spontaneous joint bleeding, deep muscle bleeding, and there can be limping in the child. So without prophylactic treatment, these children can have around 2 to 5 bleeding episodes per month, and they can have severe bleeding like bleeding in the kidneys, GI, and brain. In moderate hemophilia, the clotting factor activity is around 1 to 5%, and the presentation age is 5 to 6 years, less than 5 to 6 years. And they seldom have spontaneous bleeding. Bleeding is usually after trivial injury. And the frequency of bleeding is also a little bit less, once in a month to once a year. And in mild hemophilia, the clotting factor activity is 50 to 40%, and they do not have spontaneous bleeding. The bleeding occurs only when there is major surgery or a tooth extraction. And the bleeding frequency is around once in a year to once in 10 years. And sometimes they don't even realize they have a hemophilia. And usually diagnosed later in life depending upon the hemostatic challenges. So this is just a table to summarize. Severe hemophilia less than 1% clotting factor, moderate 1 to 5, mild 5 to 40%. So what are the complications when we don't treat the bleeding? Leading cause of death is intracranial hemorrhage. Major disability in these children is chronic joint disease because of hemarthrosis. And priorly life expectancy was only 11 years. But now it has come to near normal life expectancy, which is around 60 to 70 years. So because of the factor VIII concentrate, which is given as treatment. So previously it used to be donor derived factor VIII concentrate. Because of that, infections were common like HIV, hepatitis B, but now it is recombinant factor VIII, so the risk of infection has been reduced. But in individuals who are treated with factor VIII concentrates, 30% of individuals can develop alloimmune inhibitors to this factor VIII within 20 exposures of factor VIII. So this is hemarthrosis leading to severe osteoarthritis in this child. So coming to genetics, what is a molecular pathogenesis? So F8 gene is usually it is located in the X chromosome. It consists of 26 exons and it is consisting of 186 kb, a large gene. And most of the mutations in severe hemophilia is inversions. Around 45% in severe hemophilia is inversion mutation. And inversion is nothing but a segment of the single chromosome breaks off. It reverses its orientation and reattaches within the same chromosome. So here you can see ABCD is the order. Here because of the inversion, it has become ADCB. So these inversions occur because of non-allelic homologous recombination, which is called NAHR. This recombination between a sequence within the same chromosome itself. And this recombination takes place usually between the centromeric region and telomeric region. So here you can see the exons are arranged from 1 to 26 from telomeric to centromeric region. So here what happens in intron 22 inversion is that between the centromeric and telomeric region, there is a homologous region which gets recombination during male meiosis. So because of this, what happens is a section of exons gets inverted and this 1 to 22 goes to the telomeric region of the chromosome and exon 23 to 26 remain in the centromeric region. So the exons get haphazardly arranged. So because of this, what happens is there is a recombination inverts the distal portion of the gene from exon 23 to 26. So this disrupts the linear continuity of the F8 gene, separating its promoter and the early exons from the later exons, which leads to deficient full-length mRNA. As a result, no functional F8 is formed because of this severe hemophilia results. So there are 2,500 different mutations described in F8 gene. So this is available in a database called Worldwide Factor VIII Variant Database. So before molecular testing, we would like to do some basic investigation in male individuals who are presenting with bleeding. So it can be because of different bleeding disorder. Hemophilia is not, of course, it is a common disorder, but we have to rule out other things also. So we'll do a basic CBC with platelet count, PT, ABTT, INR. And when the bleeding time, clotting time is normal, bleeding time is normal, platelet count is normal, and APTT is prolonged and PT is normal, then we have a clinical suspicion of hemophilia A or B. So when you have suspicion of hemophilia A or B, we first genetic testing, which we usually say is intron 1 and intron 22 inversion study. This is a simple PCR testing. And only if these two mutations are negative, then we go for F8 gene sequencing. So this sequencing of this gene cannot be done through Sanger sequencing because it is a large gene. So you have to go for NGS-based sequencing. So either it can be done through gene panels or a whole exome sequencing. So so basically it should cover all the exon-intron boundaries and the promoter region also. So no genetic variations have been identified in around 2 to 18% of the patients. So it's not like every patient will have a molecular diagnosis. And sometimes hemophilia can be acquired also. And this is a tabular column just summarizing what to do first. So intron 1 and intron 22 inversion study can identify 48% of the severe hemophilias. And when you do sequence analysis of the gene, you can identify around 50% of severe hemophilia. And around 90% of the moderate to mild and moderate hemophilia are sequence variants. And rarely we can have deletion duplications also. For deletion duplication, we have to do either MLPA or an exon array. So why molecular diagnosis is important? Because certain mutations, they are increased risk of developing inhibitors. So that's why we have to have a careful watch on that. So having a molecular diagnosis is always important. Also, it helps in prenatal testing and carrier screening also in the family. So for hemophilia B, the molecular testing of choice, first test of choice is sequence analysis through exome or NGS-based sequencing platform. So around 97 to 100% of the variants are identified through sequence analysis itself. Rarely, they can also have deletion duplication mutations. So genotype-phenotype correlation, most of the intron 22 inversion mutation, the phenotype is severe hemophilia. And also severe hemophilia is also seen in intron 1 inversion, stop codons, frame shift mutations, splice variants. So basically loss of function variants. And missense variants occur in less than 20% in individuals with severe hemophilia and found in almost all patients with mild to moderate disease. So all males with F8 gene hemizygous pathogenic variant will be affected and will have clinical manifestations and will have approximately the same severity as other affected family members in the male family members. So around 35% of the female carriers who carry the F8 pathogenic variant, heterozygous pathogenic variant, are called carriers. These 30% of the carriers can have clinical manifestation like a bleeding disorder, and they can have low clot. So since hemophilia A is an X-linked recessive disorder, few points about the genetic counseling. So males are affected and females are not affected usually, and there is no male-to-male transmission seen in the pedigree. And for a carrier female, her 50% sons are going to be affected and 50% of her daughters are going to be carriers. And for an affected male, all daughters are going to be carriers and all the sons are going to be normal. And affected male in the family are usually related through carrier females. And an affected child can have an affected maternal uncle. So this usually is called a night smooth transmission. If you see the pedigree, it can have this L-shaped night smooth transmission usually. So this is a family pedigree which shows that she's an obligate carrier. This lady is an obligate carrier and this lady is also an obligate carrier, because this lady has her own son affected with hemophilia and her own brother is also affected with hemophilia A, and her sister's son, her nephew, is also affected with hemophilia A. So when a female has two male members affected in the family connected to a common pedigree, so she's called an obligate carrier. And we can see in the pedigree that her mother's uncle, maternal uncle, was also having some bleeding disorder who passed away. So this is what we counsel. If mother is going to be a carrier, 50% of her male offsprings are going to be affected and 50% of her male offsprings, female offsprings are going to be carriers. And for an affected male, when they come for counseling, prenatal testing is not necessary because their male offsprings are going to be normal and all the female offsprings are going to be only carriers. And usually other family members also, we have to tell them that the proband's maternal aunt should be screened and also their offspring should be screened. Male offspring should be screened for hemophilia. So prevention through prenatal genetic testing and pre-implantation genetic testing. So prenatal testing can be done once the pathogenic variation has been identified. So in India, the law, PCPNDT law, does not allow sex determination. So only a possible way is through you can do a CVS or amniocentesis to identify whether your fetus is going to be affected. Or you can go for IVF PGT-M. So differential diagnosis include after hemophilia A, hemophilia B, because hemophilia A and B, they are clinically indistinguishable. Only when you do factor assay, you will be able to make the difference. And the other differential, common differential is von Willebrand disease, then hemophilia C, and the other clotting factor deficiency like factor 7, factor 5, factor 10 deficiency, factor 2, and combined vitamin K dependent factor deficiency like 2, 7, 9, 10. All this can present with prolonged PT and ABDT. And sometimes DIC, liver failure, can also present with factor VIII deficiency. And inherited fibrinogen disorders can also mimic a bleeding disorder. And some platelet function disorders like Bernard-Solier, Glanzmann thrombocythemia can also mimic bleeding disorder. So how do we evaluate these patients? After a history, pedigree, baseline CBC and platelet count and viral markers. So these patients should be subjected for genetic evaluation. So molecular genetic testing is advised. Once pathogenic mutation is identified, so we have to refer them to a hemophilia treatment center. So in small clinics, usually treatment is not suggested. It is always recommended to refer them to a hemophilia treatment center or a comprehensive care center under a clinical hematologist. So in these comprehensive hemophilia care centers, multiple disciplines are available for diagnosis, treatment, and management of complications. So consultation with a clinical geneticist is particularly important for a new diagnosis and also for females during childbearing age. So treatment is usually different guidelines are available, but standard guidelines which everyone follows all over the world is World Federation of Hemophilia guidelines. So they have a very beautiful PDF where everything related to hemophilia is described. And treatment should be coordinated with the hemophilia treatment center. And IV infusion of recombinant factor VIII or a plasma derived factor VIII should be given within an hour of noticing symptoms immediately. And dosing is usually weight based and also based on the target levels and severity of the bleeding. And duration of the therapy also is usually varying depending upon the severity of bleeding. And all the staff should be able to perform a perfect venipuncture. And patients of age group 2 to 5 years, usually their parents should be trained to administer the infusion at home itself in case of severe bleeding. So this World Federation of Hemophilia Guidelines, third edition was given in 2020. So it's a easily accessible free edition, so which everyone can go through. So the priority in treatment plan is prevention of bleeding and prevention of joint damage. So you should promptly manage the bleeding episode, including physical therapy and rehabilitation. And you should also give pain management and management of musculoskeletal complication. And after a few infusion of after 20 infusion of factor VIII, you have to check whether they are developing any inhibitors. And you should also monitor the quality of life. Psychosocial support should be given, dental care should be given, and they should also be referred for genetic counseling and also for caregiver education and support. So whenever you treat a hemophilia A patient, you should make sure that there are lab services available which can do PT, ABTT, INR, and there is emergency services round the clock, and blood bank is available, and clotting factor concentrates, FFP, cryo, vasopressin, tranexamic acid is available. So only then in a tertiary care center you can manage these cases. So in mild bleeding, usually 30 to 40% factor VIII activity is recommended, and severe bleeding 50%. In major surgery or a major dental procedure or life-threatening hemorrhage, usually 100% factor VIII activity is needed. And usually factor VIII, when given at the dose of 1 unit per kg, it can increase the levels by 2%. And half-life is around 12 hours. So good practice is always infant males should not be circumcised unless hemophilia A is ruled out with a simple APTT, and if present, should be treated with factor VIII before and after the procedure. And immunization should always be given in these children subcutaneously and not intramuscularly. And whenever there is mild hemophilia, bleeding episodes can be managed with vasopressin itself or tranexamic acid itself. And in minor surgical procedure or dental work also, you can use DDAVP. So single IV dose usually triples the factor VIII, and nasal formulation, nasal spray is also available. And usually it should be given only in inpatient setting. And if you are giving IV, a test dose is necessary. And serious adverse effect is hyponatremia, which should be watched for. And continuous 3 doses should be avoided. And other treatment include, you can give plasma therapy, cryo, epsilon aminocaproic acid, tranexamic acid, fibrin sealant therapy during surgery, or a bovine thrombin or recombinant thrombin can be used during surgeries. So in severe hemophilia, usually the primary prevention is prophylactic treatment. So prophylactic to factor VIII concentrate should be given 3 weeks a week or every other day to keep the factor VIII activity more than 1%. So nowadays, newly modified recombinant products are available, which can be given at lower frequencies. And the greatest benefit in hemophilia, severe hemophilia, is seen when the treatment started less than 2.5 years of age, before the first bleeding, before the first hemorrhasis itself. And secondary prophylaxis starts when the joint damage has already started. And the common advice we give to the patients is to avoid herbal medicines, to avoid NSAIDs, IM injections, and contact sports, which have high risk of trauma, particularly head injury. So coming to other therapies, like so surveillance, usually young children with severe hemophilia, usually 6 to 12 months in the hemophilia treatment center, they should be having a surveillance. Other mild to moderate cases, you can have once in a year or once in 2 years. So in severe hemophilia, usually what we have to do is after 10 to 12, 20 exposures of factor 8, you have to check whether they are having any alloimmune inhibitors. And if they don't have inhibitors, every 3 to 6 monthly, you can monitor for the inhibitors. And in pregnancy management in carriers of hemophilia, carrier testing should be done before, if they have a family history, carrier testing should be done before conception. And if she is a carrier, we have to offer prenatal testing. And if she is if she's a carrier, factor 8 activity usually rises in pregnancy. So in pregnancy, the risk of bleeding is less. But during delivery, after 48 hours, there's a risk of delayed PPH, because the F8 activity comes to baseline normal after 48 hours. So there is risk of PPH. And if the factor 8 activity is less than 40% in a carrier female, you have to recheck in the third trimester and plan the delivery accordingly with factor replacement in a tertiary care center. And if the male fetus is having severe hemophilia, trial of normal labor can be given according to recent guidelines. But in some studies, it says that if a fetus is found to have severe hemophilia in a male fetus, then cesarean section is recommended. And usually, avoidance of instrumental delivery like vacuum forceps should be avoided, and scalp sampling of blood, fetal blood sampling should be avoided. So newer therapies include extended half-life recombinant factor 8. So because of the pegylation or FC fusion or albumin fusion, their half-life is extended, so that every week instead of 2-3 infusions, the infusion can be given once in 5 days or 1 week. And now recently, gene therapy has been approved by the FDA in 2023. It's a adeno-associated virus gene therapy, and it's a one-time IV infusion, and which carries the normal functional F8 gene copy and goes to the hepatocytes and induces normal production of factor 8. But long-term durability is still under evaluation. So how to treat factor 8 inhibitors by bypassing agents? So bypassing agents are nothing but the need for factor 8 by activating the need for factor 8 is reduced by activating the other coagulation cascade. So the most commonly available methods are porcine factor 8 or activated prothrombin complex concentrate, factor 7, recombinant factor 7, or a immune tolerance induction for these inhibitors. And now recently introduced monoclonal antibody that bridge factor 9 and factor 10, emicizumab, is very famous and it's very useful in therapy. So this is to summarize the alternative agents which are used in prophylaxis. So emicizumab is usually given as prophylaxis and not given for acute bleeding. So it is given subcutaneously 3 milligram per kg weekly for 4 weeks. Then the dose can be reduced to 1.5 milligram per kg weekly. And if you have fresh bleeding and the patient is having inhibitors, very high amount of inhibitors, you can try factor 7, activated factor 7, and activated prothrombin concentrate also. But the major risk is that they can induce thrombosis. So now recently CMC has published this article, lentiviral gene therapy. So here the patient's own stem cells, CD34 stem cells, were modified with a lentiviral vector carrying this F8 gene. So this was a major breakthrough in severe hemophilia patients with no inhibitors, and 5 patients were treated with this lentiviral gene therapy, and they have identified stable F8 gene expression, and bleeding rate was 0, and follow-up was done till 27 months, and they have noted no serious adverse effects. So now newer advancements include CRISPR-Cas9 based gene editing technology. So these are just happening in animal models and cell lines like induced pluripotent stem cells. So where the primary mutation intron 22 inversion, Cas9 cuts the flanking inversion region and the homologous recombination restores the wild type gene. So beyond this factor VIII replacement, there are hemostatic agents also coming up called rebalancing drugs. These are novel therapies. These are not routine standard of care, but long-term therapy safety and efficacy long-term study is needed, but still hold some promise in the future. So these are some TFPI inhibition called tissue factor pathway inhibitor. So these are monoclonal antibodies, concizumab, marstacimab, and there is RNA interfering, small interfering RNA therapy also, siRNA called fitusiran, and which actually acts by knockdowning this antithrombin. So there is also APC inhibition, protein S and protein C inhibition through this some molecule called serpin PC and VGA039. So these are all under study. So basically, they actually are acting as hemostatic agents without the need for factor VIII therapy. So some points regarding hemophilia B. So I already told that hemophilia A and B are clinically indistinguishable. So the only way to differentiate is by doing a factor IX assay and having a molecular diagnosis. So this can also have three types: severe, mild, moderate. So genetic variants, most of them are sequence variants, and sometimes deletions are also possible. So basically F9 gene sequencing is sufficient through NGS technology. And especially the most important point in hemophilia B is this treatment is also same through factor IX concentrates. You have to treat hemophilia B. And pregnancy consideration is very important because factor IX levels do not increase in pregnancy and they are at risk of PPH. So factor infusion support during delivery and after delivery is important. So thank you for lending your ears and have a good day. So that's all about hemophilia A and B.
Insightful presentation. Yeah, I just want to introduce you meanwhile, but you started early. You have a great profile. Yeah, meanwhile, we have a couple of questions.
Sure.
We'll go to the Q&A. Prior to that, I have a question like, in acquired hemophilia condition, as you know, it's autoimmune condition. So where we usually prefer to go immune suppression therapies. So what if the acquired immuno was a patient of elderly or, immunocompromised patient? So how do you deal with the cases? How challenging it was?
So I'm a clinical geneticist basically. So I think this requires because already elderly and having some autoimmune condition, having autoimmune related acquired hemophilia. So this requires treatment under a hematologist and also with the immunologist. So usually multiple disciplines will be acting. So we will be helping with the molecular diagnosis. If it is genetic, we will be dealing with it. But if it is going to be an immune system related problem, we'll be usually referring them to an immunologist and a hematologist.
Okay. Okay. And I just want to know, in particularly pediatric cases, how to know, like newborns, or they usually have internal bleedings. So how to know or how to, detect as early as possible internal bleeding between the joints?
Especially if it's a male baby and having some spontaneous bleeding or some bruising, easy bruising, or internal bleeding, serious internal bleeding, you have to definitely screen them for hemophilia. So the basic thing is do a CBC, platelet count, PT-INR, and APTT. If the APTT is prolonged, then definitely we'll have to suspect hemophilia.
Okay. Okay. Yeah, but my question is, in a spontaneous hemophilia condition, because we don't have any family history and we don't have any,
family history is not necessary.
Yeah.
So yeah. So you don't have to rely on family history. You have to screen any male having bleeding for hemophilia, family with or without family history.
Understood.
So any questions in the chat box, we would
check. As of now, there is no questions so far. So if any questions are there, let us know in a couple of minutes. But meanwhile, thank you so much for accepting
Thank you. Thanks for the
your
invite.
busy time. Yeah.
Thank you. So
We'll
if there are
wait
no
for a minute.
questions, yeah,
Yes,
we'll wait for
we
a minute.
consider. Yes, because there is no more questions. Yeah, I think question is there. Which community in India has high prevalence?
I don't know that. I have to look up.
Okay. Okay. Okay, then we consider it as no more further questions. Thank you, Rupa. Thank you.
Thank you.
Having
Thanks
your
for the
time.
invitation. Thank you.
Yeah.
Have a good day.
Thank you. Yeah.